All right, so dear doctors, thank you so much for joining the session. Today is a recall class. We'll do the May recall. And thank you so much for joining the session. This is Dr. Shahriar. I'll be taking that today's session. So how you all guys are doing? I hope well, and I hope you are doing really, really well, everything. So we'll be starting the May shortly, but before getting into the session, a small important thing. You guys probably have given a link for this particular thing, which often you call as a video channel library. Are you guys connected to this? I'm sharing a link. If not, please check that link if you're connected with this uh, video channel library platform or not. All right. So this is very, very important for all of you. All right, everyone. So please check. I just shared a link. Please click that link, please, to enter. Or already some people now. When you enter, I'm just demonstrating this one, what to do with it. In this one, you see like so many people and this and that. So a lot of our doctor who passed in previously are also added here actually. So you can also find out them. First of all, and can text them. This is something we call networking. This is only in SME you can get, we have like alumni, this, that some are preparing for MC2, whereas some of them are already doing job in Australia. So from the members checklist, you can find that one. Secondly, coming why this particular channel is helpful. So I click usually the media. Normally anything extra, something we also post anything interesting. Like we recently posted study partners wanted. We have various batches, not only recall 3 months course, we have 5 months course, we have the Netflix type recorded courses. So different people have different, but if your time zone and this that matches, so you can also apply here. You can also apply here actually everything. Great. So this is the thing. And in the beginning, I'd like to consider this thing is the sound is loud and clear or not. Volume is low. I think, okay, let me check one more time. No, I think it's because I'm talking in a small tone. Actually, my voice is normally in a small tone, actually. I think I was talking in a small tone voice, actually. Is it okay? The voice thing? Is it loud and clear? I think it's clear, I think. Yeah. Use, I think, headphone because it's the same setting which I'm using. I think it's fine. I just double check the system. I think it is okay. Sound is okay. Okay. Let's focus here. Maybe I was talking in a little low pitch tone, actually. That is the thing. Sometimes if you keep talking in a high pitch tone, sometimes your voice can have issues, this and that. Okay, guys. So coming to this one, video channel library. Yeah. Better use it. Now, I'm using headphone definitely. I'm using, yeah, headphone, professional one, professional system. So don't worry. Those people are not using, those um, not using headphone, please use it. Great. Coming to this one, I'll try to talk in little louder vocal now. That's okay. But if you're using tab, this and that, of course, you can hear little less actually. Yes. Great. There's a thing called media. There's a thing called media. You can also do the demonstration. After clicking the media, there is a album. We click the album. It comes like this actually. You can also do it with mobile, but it's better to do it. Now, if you system-wise, some videos are also given actually, some of the third-party videos. So if you want to see you have basic problem and this and that, but in this batch, most people are advanced, so we believe that. But some additional video you can check here, but we don't recommend that one much because most people are advanced here. So which particular albums are useful here? Mostly useful here for you is this one, this radiology. When you click this one, there'll be so many radiology pictures. So you should check those radiology album. I keep updating that one even if you find 2025 to even 2026 updates like small anything new came up in February there will be updates, so maybe one or two new slides will be there for the radiology. Already I have been posting that one for many years. Then there are a few things about the control recall. Not every month so many control recall, but maybe 5 or 6 control recall. So we also try to add them. So you can check this one as like a question bank. Very important. Often tested this kind of thing. So this one is helpful. Okay, so this one is very, very useful. In exam related tip, you can double check this one. And special before exam. Now, what is this special before exam? The special before exam, there's so many topics. Example, psychotherapy, then there is a fundoscopy, then you can see ECG, then there's a contraceptive screening, then there's the growth chart, cardiac risk assessment, CTGs. Okay, then the radiology, then dermatology. All right. So orthopedic top five, yes, and also the biostat. You see these particular videos, if you count, you can almost cover almost like 30 questions, I believe. Okay, so from this spatial before exam videos, you can nearly cover like almost 30 questions. So which before the exam it's like an excellent post actually. All right. Now, these are some of the information special before exam, control recall, radiology, very helpful, useful as a folder for mnemonics. And I hope to increase more in coming days actually. And other than that, there's a very like important when you pass the MC part 1, there's a e-recruit and interview questions actually. Okay. So you can see few of them are there. You can also check that one after you pass it. So you will be added to this one. Okay. Good news is you will be added to this particular group, guys. Okay. Even after you pass, you will stay added. Okay. Please let me know in the comment section if this demonstration is helpful. So, radiology album, special before exam album. Time to time, you check these 15 videos. From these 15 videos, you can cover 30 questions. That's a plus point. Exam tips. And about exam tip, guys, try to get the last day of the month or the last 2 dates of the month. Okay, so this is the most important exam tip for this batch. Whichever month you are taking, try to get the last month, last 2 days. Now, frequently asked question, doctor, I'm not getting the last day. What to do? I'm not getting the last day, then what to do? Okay, I'm sharing it again, my dear. Uh, So I shared this one again, directly the album link. You can check that one. So special before exam, radiology, this one, exam tips, this one, and of course after passing, you can check the e-recruit and interview questions. Let me know in the comment section if this demonstration were helpful for you guys. I just take out the screen so that I can start the file. Okay, let's go and try to start our today's session. Actually, are you guys ready? Please let me know in the comment section. Okay, question number one: a 60-year-old man presents with evaluation after routine screening mammogram. Okay, so it's a breast-related certain thing. 3 centimeter suspicious lesion in the upper outer quadrant of the left breast. Upper outer quadrant considered as a high risk. Okay, let's say any lymph node. Low lymphadenopathy, no constitutional cancer symptoms. Okay, the lesion is speculated on imaging, classified as something like this, and highly suggestive malignancy, no prior history of breast procedures. Clinical examination correlated with the film but non-mobile mass. Now, what is the most appropriate next step in diagnostic workup? Yes, please. Always check what has been done, especially for the breast. And what you can do, also check the age group. And that particular age group is highly suspicious for what? In this case, they mentioned like suggestive of malignancy, but main exam, a lot of cases I have seen, they didn't mention about highly suspicious for malignancy or something like that. They just mentioned the age. About like 60 years of age group, it's automatically highly suspected for malignancy, honestly speaking. So in this particular cases, let's go and find it out. Actually, a suspicious breast lesion. And what we are thinking in this particular case is a very high chance. Very high chance. What do you think? Which one do you think is the best? So, core needle biopsy is the first line diagnostic tool. Okay. Again, double checking the answer. FNAC or core biopsy? Core biopsy means if you find a certain type of uh, lesion, okay, if you find a certain type of lesion, are you going to do an FNAC separately, or you want to, like, after doing the ultrasound and this and that, certain things, so you will do the core needle biopsy. Double checking again, I even did have one cancer patient in my family, and also this is common in our general practice actually. Core needle biopsy, my dear, yeah, core needle biopsy. You can Google it, my dear. That's core needle biopsy. Core needle biopsy at the time, you open in the while doing the surgery, and then remove that piece and send for the histopathology actually. Right. So we prefer that word core needle biopsy. Often these particular two things gives a lot of confusion actually. So core needle biopsy is you open it and also do the surgery and remove that particular part. Okay, core needle biopsy. So corneal biopsy is the right answer in this case. Corneal biopsy is preferred initial diagnostic for evaluating suspected breast cancer. Why? More accurate than FNSC in distinguishing between the in situ and invasive carcinoma. I think your answer sits here, my dear doctor. So the question someone asked, like, so this will be more accurate than the FNSC, certainly, because you are doing it in an open surgical field, distinguishing between in situ and invasive carcinomas actually. Great. FNSC, else like, cytological samples only at the same time. Guys, please mention this one as a clear so that we can move to the next one. This mention is clear actually. So we have that confusion between, this is not a new question, guys. I have seen this question also in past in MC. So again, it came newly. I have seen probably this question maybe 5 6 years back. I have seen that one, and so I was very sure about the answer. Actually, it's like a core. Actually, maybe some of you didn't practice that one, but this is very common in our practice. It's like uh, doctors get confused between FNSC and that. Um, yeah, core. My dear, I mean, I highly recommend you later Google it, because this is, I think, more related to MBBS level thing, like what is FNSC, what is core biopsies, right? We are at much advanced level because we're dealing with MC now actually. Okay, so those of you who still have the confusion, you don't know about what is FNSC is, what is biopsies, I highly recommend you please Google it later actually. Okay, coming to this one, I mentioned like core and the FNSC major difference, but if you don't know what is FNSC, how to do it, actually, I mean, I would say you can Google it first, and then you can check some of the YouTube videos how an FNSC has been done. A lot of people come from different medicals. Maybe some of them didn't see it. Actually, I don't blame them, anyone actually. Next question. 55-year-old presents emergency living complaint, generally suffering pain, nausea, this, that. Okay. And for first few days. So first few days, chief complaint always double check. No significant medical external examination. These are the problem. Blood pressure is this, so not looking so well. Abdominal pain and blood pressure is down. Pulse is high. Laboratory things are given. Very interesting. Check the laboratory. Calcium given, creatinine given, elevated, albumin normal. Okay. So what is the most of your next in the initial management of the patient? Great. Keep going, guys. If you can also write one or two, explanation would be also really more nicer. Okay. Yes, please keep going. Before revealing the answer, one more time, chance. Most people have answered this one C, and our final answer is also considered C. Initiate normal saline. Now, why initiating normal saline? I repeat, why initiating normal saline is more helpful for you at this point. Any idea? First of all, we have a hemodynamic instability. Hemodynamic instability. Okay, and do we have anything, in the lab? Does anything also have issues? Look at like certain levels, like calcium levels, serum calcium levels, creatinine levels, this and that. Okay, so looks like it's more like a hemodynamic instability at this point. So I think among the options, I think as soon as possible, and it's a possibility calcium level can be affected over the time. So initiate normal saline is more recommended. Initial normal. So why IV saline first? Restoring intravascular volume, that's most important, and also improves renal perfusion. Do we have a issue with the renal perfusion here? Do we have any issue with the uh, creatinine level here? Let's come back and see with the main question. We have some issues with the renal perfusion of the creatinine here as well, right? So considering everything, so IV normal saline is the solution in these cases. IV normal saline will be the solution. Okay, so it will also enhance the GFR in case urinary calcium excretion at the same time. Wonderful. Okay. So first line, and as a IV nutshell, isotonic saline, aggressive rehydration is essential in this case. Great. That level we have, that calcium may be a little up and this and that. So when you give the normal saline, it will be corrected. Also, your patient is hemodynamically unstable at the same time. You can check more details, something like um, therapeutic guidelines and this and that would be also nice. I took that reference from the therapeutic guideline, by the way. I hope that's clear. Last question. 68-year-old man presents with a lower back pain. So what is our chief complaint in this case? Chief complaint here is a low back pain. Now pain is dull or at night and not relieved by analgesia, increased fatigue, and this is over first 3 months, and there is no history of trauma. Physical examination revealed there is tenderness over the lumbar vertebra, so no focal neurological deficit. This is the important line. Low back pain. Low back pain, you always double check if there is a radiation and neurological deficit or not, because the diagnosis can change actually. Also, the pattern of the pain, it's a dull pain or at night actually. Any idea, any cases after seeing the laboratory, what it could be? Creatinine little elevated, we can see. Calcium, little elevated, we can say that. Calcium elevated, hypercalcemia, mm, kidneys also affected. Some people are also mentioning a mammonic crab. You must be knowing what is that mammonic crab is related to. Also, our age is an elderly age group. Is situation like uh, okay? So let's go for a. I mean, let me not tell you the diagnosis. What is your suspect? What test you to do to make a diagnosis? Come on, guys, one more time. Some of you are not answering. Some of you are not answering that one. Coming to this one, final one is a protein electrophoresis. Now, why protein electrophoresis? Because it's related to the diagnosis. The answer is why protein electrophoresis? Because the answer is related to this diagnosis. Okay. The diagnosis is multiple myeloma, hypercalcemia. Then there is creatinine level elevated, back pain, anemia. All these things are indicated. Let me show you something. Let me show you something if it's okay with you. Yes, please. A very popular mnemonic actually out there. One of them is called crab or old crab. So multiple myeloma, old crab, so old age, calcium elevated, renal failure, anemia, lytic bone lesion. Clear everyone? So this is a very classic one. It's a very classic one for this multiple myeloma. Very classic one for the multiple myeloma. Coming back to the question. Further confirmation, of course, protein electrophoresis, definitely we can do. The CRAB criteria is this one. Okay. About the MRI, some people are answering, useful later for assessing if there is a cord compression. Actually, some of them are not considering it as a multiple myeloma. They were considering it something else, maybe related to a spinal cord disorder. If it would have been spinal cord disorder, if it would have been, you see, they have also mentioned one thing. Is there any focal neurological deficit? Did you find other red flag, guys? Did you find the other red flags here of considering that MRI actually like urinary problem? Along with the back pain, there is urinary problem, radiating problem, and this and that. So those were not mentioned. So I think that's the reason we are not going for MRI, but we are going for the serum protein electrophoresis. Is it clear, everyone? I hope it is. All right. I think it's already clear. We are answering this one based on the CRAP criteria. Question number 4. A 32-year male in a construction worker, always occupation is important, present the emergency after falling from a ladder. Falling from ladder, lot of things can happen, but depends in which way the person is falling down. Actually, he's falling outstretched right arm, so your direction is falling is important. Reports difficulty in extending his wrist and finger. On examination, there's a weak in the wrist and finger extension, resulting in characteristics wrist drop. They already mentioned the word wrist drop. Sensory loss is noted over the dorsal aspect of the hand and posterior forearm. Reflexes are normal in the biceps and the triceps, most likely injured nerve. I think the word itself, if I just try to draw it, right answer, let's confirm, radial nerve. Okay. The wrist drop is classic presentation for the, so let me try to W. Mm, We actually remember this thing in this way. So the word wrist, the word R is there. So that R thing for radial. Is it clear, everyone? The radial wrist rub, very classic for the radial wrist rub. That is very classic. Like if uh, carpal tunnel type of feature, median nerve, or median nerve also can be affected. Uh, one in the wrist, okay, one in the elbow. Many of the nerves can be like one affected in the wrist and in the elbow. So you have to double check which one in which particular area it is getting affected. Very, very important actually. Right. Now here it is mentioned. It is wrist drop, certainly, and we know what is wrist drop is. Right. Now this type of injury commonly occurs with humeral shaft fracture. So exactly where is the site of lesion? Humeral shaft fracture or direct trauma compressing the radial nerve at the course of the spiral groove of the humerus actually. Are you getting it, guys? At what particular area, if radial nerve is injured, that you can get the wrist drop actually. Okay. Few more others like sphenoid median nerve, like controls the wrist flexion and thumb opposition, does not affect the extension. Wrist drop is mainly related to extension actually. So your extension of the hand muscle fails, so then there is the wrist drop. So it does not cause affect the extension. Radial nerve does the extension. Ulnar nerve controls the finger abduction or adduction, does not cause the wrist drop. Musculocutaneous nerve controls the finger elbow flexion actually. So it's very also important. Elbow flexion, not wrist or finger extension. Is it clear now, everyone? Individual, all the terms has been verified. This one directly related to extension. These are not related to extension actually, rather than different one has a different function. Guys, you need to confirm that these things as a little clear by at least not getting lazy during the class. Lazy people fails more in the exam. Understand these things. Okay. 45 years like man presents the low back pain that began while lifting heavy box. He describes sharp pain radiating to the left part of down, the posterior thigh, and cuff to the plantar surface of the foot. The pain worsened with the sitting and improves slightly when lying down. Now please highlight this line more than others. So the pain worsened with sitting improves. Again, the question is related to low back pain in a yeah, and began when lifting heavy. On examination, in SLR test is positive. You know what is SLR test is? I hope so. If not, maybe you can just check in YouTube. SLR test demonstration actually. Very important, no focal deficit in that way, no bladder and the bowel dysfunction. What is most important to assess this patient? 5 more seconds. Okay, let's go for the final answer. And the final answer, we have picked up this one, that is ankle reflex. Now, why is that? This is more related to pain worsen on sitting, improves slightly when lying down. Cellular left, yeah. There is a little bit things related to radiating to the left buttock. Sharp pain radiating to the left buttock. Okay, coming to this particular, the patient's symptoms. This is a situation, everyone understood this point. Like this is a question related to radiculopathy. First question is what is this problem? Is it only back pain or is it a radiculopathy type of back pain? It is radiculopathy type of pain. If it is radiculopathy, so definitely there are some, you know, nerve that is affected, and due to some disc, if there is anything lifting heavy, yes. So L4, L5 disc herniation, disc prolapse may be a high likely reason, which is radiating to the posterior thigh and the sole of the foot, often accompanied by weakness of the plantar flexion and diminished ankle reflex. Okay, so here is your main line. So the ankle reflex is mediated by S1 nerve root. So we like to check the ankle reflex of the patient actually. Is it clear, everyone, why we are checking ankle reflex in this person actually? Because L4S1 disc, when lifting something heavy, got affected. And how we know? Because radiating pain, radiculopathy actually, and it is going to the leg up to the sole of the fin. That means L5S1 affected actually, because it is going to the foot. The radiation is going up to the foot. Okay, so this situation, this disprolapse situation is associated with weakness in the plantar flexion, so and diminished ankle reflex. So ankle reflex checking is important. Few of the other similar things like patellar reflex on L3, L4 nerve root, quadriceps, L4 nerve root primarily, very important quadriceps, hip abduction L5, ankle and S1 nerve root here. There is another extra thing which will be important for you. Let me show that one. Should I show that extra thing or move to the next slide, guys? Maybe you can take maybe at least a screenshot. Another question often can be given in MC, peroneal nerve, similar kind of situation, radiculopathic pain, peroneal nerve, sciatic nerve, L5 radiculopathy, and some cases motor like a cortical lesion. Please take a picture of this one. This one related question also can be given in MC. Okay. Next question, everyone. This time a young person, 19-year university student with a 7-day history of sore throat, fever, malaise, swollen neck gland. On examination, he has both-sided lymphadenopathy, palatal petechiae, and mild splenomegaly. When you do test, streptococcal antigen test is negative, full blood count, lymphocyte atypical. So what is the diagnostics test to confirm the suspected condition? Yes, please. First of all, maybe you can put a diagnosis in your mind. Appropriate diagnostic test they're asking. Okay, check the previous one. Sore throat, fever, lymph node. Sore throat, fever, lymph node. Very young person. Also lymphadenopathy. Streptococcal antigen negative. So can it be rheumatic fever? Quick question. Can it be rheumatic fever when like streptococcal antigen test is negative? like that ASO thing is probably negative. So we are not going for a throat culture thing first in this case. Instead, we'll think about something else. Because in the blood test, it is mentioned atypical lymphocytes. So it is more going towards, at this point, higher chances you can perhaps go more towards the this one actually. Positive mono. Now, quick thing, heterophile antibody test or monospot test. Is this a test for Epstein-Barr virus? What do you think? Infectious mononucleosis. So prolonged sore throat, fever, bilateral severe lymphadenopathy, and this and that. So this is the thing. Is it clear, everyone? Diagnosis is infectious mononucleosis, heterophile, or monospot test. So monospot test is Epstein-Barr virus as a diagnosis. First line for yes. Any questions or should I move to the next slide, guys? Great. I think it's more about a right diagnosis and then going forward. Okay. So one of them is a monospot test. That is the thing. We need to do monospot test first to then to go to the next one. Clear? We didn't go for E directly. That's why E. That's why not E actually. I mean, we don't do directly like the Epstein-Barr virus antibody test without not doing the monospot test. Clear? Yeah. Because here is a confusion between two particular tests, because one is a rheumatic and one is that one actually. So the rheumatological one is being done. So first you need idea about are you going in a right direction. So in that case, definitely you need to do the monospot test first. When monospot become positive, then you go for the like the Epstein-Barr virus antibody test. Next one. 30-year woman found to have 3 centimeter liver mass. See, another mass. Lot of type of masses are important in exam. Lung mass, testicular mass, thyroid mass, renal mass, adrenal mass. Now, liver mass is also 3 centimeter liver mass with abdominal imaging performing evaluation. Non like a of non-specific right upper discomfort, no history of hepatitis, alcohol use, or travel to endemic areas actually. So this is a negative history. She has been taking oral contraceptive past 2 years. Laboratory test is these things are given like that, and the mass is well circumscribed and no evidence of cystic and calcium component. What is the likely diagnosis? Three-centimeter mass. So this is the issue here. If you see if there is any other particle, no history of this thing. And also there's a special history of oral contraceptive. Now having that oral contraceptive, you can also highlight. Okay. Is it now hemangioma or is it a adenoma? Okay, before going into this one, I think liver cancer related. Let's see if we have something. So here it's a slide we have, and two slides I want to show you guys actually. Guys, let me know in the comment section. Should I show you those extra slides or should go only through the slides would be enough for you? Do you want to see the extra ones actually? Do let me know. Okay, thank you. Now here we go. If you see, this is a previous old slide actually, which I bring out from computer. Some cases you'll be given CT scans actually. So this one is a classic for liver hemangiomas. You will see these bloody areas. This one has a so much dots, so metastatic cancer. Single, like a ring occupying, like a liver cancer. If you compare this one and this one is irregular, this one is very even and smooth. So this is cyst. So this is general idea the CT scans can be given. Other than this thing, there's some other liver tumor like cavernous hemangiomas, which is usually benign. Another one is a hepatic adenoma, benign liver tumor, often related to oral contraceptive use. Very interesting. Okay, now most of you have answered this one as a hepatic hemangioma. Hepatic hemangioma. Now, are you sure about is it hemangioma? And because a long time use of oral contraceptive, your answer is adenoma. Final answer. This is certainly your answer should be adenomas. I think I should add this particular extra slide. Okay, so you can see this question has been tested in 2021 as well because I saved this one as a 2021. Now we are doing it in 2026. So imagine, so this is a high-end one. It has been tested 4 5 years back. So hepatic adenoma as a OCP users. I think we have seen already from a computer slide. So benign and OCP user, very high chance adenoma. Great. Next question. 29-year man with a 6-year history of schizophrenia treated with haloperidol. I am sure you know what is haloperidol is, like antipsychotic medication, and which is usually given for uh, psychotic condition like schizophrenia. Despite good adherence, he continues to experience persistent positive symptoms, including auditory hallucination, trial with 2 different psychotic medications. Second generation have failed to achieve control, and he has no significant medical comorbidities. What is the next step in the management? Come on, guys, 10 more seconds. So, in spite of treating this thing with haloperidol, he continues to experience positive symptoms of schizophrenia. Okay, so in that case, so that initial treatment and that thing probably failed actually. Okay. Schizophrenia continues to experience persistent positive symptom despite a very strong drug, which is the uh, haloperidol. When haloperidol is given, which is a one of the drug which is very potent, one of the haloperidol. So even in spite of haloperidol, if you can't treat a positive symptom, in that case, it defines treatment-resistant schizophrenia. Required escalation with the most effective available agent. Now, question is, we have certain other options too, and we also have clozapine. Normally, why don't we prefer clozapine? But clozapine has very good like a response. Okay, but why we don't use clozapine all the time among the atypicals? It is one of the reason it can cause agranulocytosis. So he said he has no history of medical condition or history of agranulocytosis whatsoever. So the thing is, we can consider giving the yeah close up in here because it is a treatment resistant case actually. Yes. So close up in for the as a last tutor. Did you read this thing somewhere that clozapine is a something which is used for the as a last resort, often as a last resort. Haloperidol itself is so powerful actually. If haloperidol failed, you can think the other olanzapine and this and that will fail as well. So risperidone, olanzapine, aripiprazole unlikely to be effective if two prior antipsychotics have failed. You understand this line, guys? So this is the reason why we don't introduce the others, because in spite having some of the treatment, um, yeah, powerful drugs, this thing failed. So there is lot of doubt that these things will be successful actually when haloperidol and consecutively failing. So you need something uncommon to treat this thing. As like I can give you an example, like some of the UTI cases when general drugs you will keep trying and if it is not working, then which particular drug we introduce? We introduce nitrofurantoin, right? It is uncommon. It also has side effects. It is uncommon. It also has side effects, but its result is excellent. Nitrofurantoin, the results are excellent. So this is a question again, a little controversial, but I think it's close up in. Since they're separately mentioning about uh, that word, like there's nothing about granulocytosis, so I think we can start the close up in here. Next question. A 60-year-old woman presents with a routine check with the asymptomatic and during examination. Single vulval ulcer, yellowish discharge, raised border on the left side of the labia minora, so genital area. The lesion appeared indurated, non-tender, hiddenized pain, pruritus, dysuria, systematic symptoms. Again, lot of negative things given. There is no significant past medical history, no or any immune suppressive medication. What is the next step in the management? If so, open ask questions like the appropriate next step. Vulvar ulcer. 10 seconds more. I'll give time to think. Those of others are not answering, please try to answer. Okay, going for the answer, guys. Some people answered, I think, earlier D as well, but most people have answered C. And the correct answer is here is C. Is it important to do the biopsy when there is a vulvar ulcer, when there is a genital ulcer? Okay, and it is persistent. Is it important to do a biopsy of that particular lesion? Now, biopsy is essential. This particular person is 60 year, by the way. Please note, if it would have been early age group, we'll think about something else like rule out the STDs. But this is the elderly age group, elderly postmenopausal and vulvar ulcer. So postmenopausal is a chronic vulvar ulcer, even if you're asymptomatic. Malignancy you should rule out. Vulvar disorder, there is a chapter in John Murtagh. Did you know, guys? There's a separate chapter, vulvar disorder in John Murtagh. If you just can check in the gynae section, you will find a chapter like so. There you will find the vulvar disorder and vulvar cancers actually. So vulvar squamous cancer should be excluded. So biopsy you will need to rule out the histopathological things. Is it clear, everyone? So we need a biopsy. I'm showing the question again. So biopsy because postmenopausal vulvar ulcer highly suspected for a malignancy. Now, looking at this question as the ulcer, raised border, yellowish discharge, does it look anything like lichen planus? Because lichen planus in that particular chapter, vulvar disorder, is another important topic. You'll often see like lichen planus is given. It's more like eczematous, itchiness. Those are the chief complaint. but this one is not the same actually. So topical corticosteroid, which is a treatment mainly for the lichen cases actually. But you will think about the lichen after excluding the malignancy. Did you know this information? Zank smear is can be done for the herpes simplex cases. Perform Zank smear. This is done for the herpes cases. But herpes cases, are they non-tender or are they tender? Certainly, herpes means they are usually tender and painful. So that is also out. Observation is a different thing, but if it is a malignancy, later it will be too late. So you cannot delay the diagnosis. Everyone, should I move to the next slide? So it's a chronic vulvar ulcer should be ruled out for the malignancy. Chronic vulvar ulcer in a postmenopausal woman, chronic vulvar ulcer should be ruled out for malignancy. Then, if malignancy ruled out, later you can look forward to lichen, eczema, or any other thing else. If it early age group, you can consider checking the STDs perhaps first. Next question. Again, a 90-year, very old age. 90-year-old man brought by the family due to increased weakness, very normal, for several weeks, and physical examination has some findings. Okay. Lesion is this 1.5 centimeter asymmetrical border, pigment varies, and area of ulceration. Patient reports like he has not noticed the lesion before and denies any pain trauma. There is no history of previous skin cancer. What is the next step in the management? First, you need to suspect what you are really thinking about this actually. Darkly pigmented irregular skin lesion in his back. First of all, what you will think about this condition? I think most of you will think this thing as a melanoma. If you're thinking this thing as a melanoma, should you start a drug or should you do a excisional biopsy? So definitely here in this case, definitely, if it is a melanoma, a full thickness biopsy is highly recommended. Full thickness biopsy would be highly recommended. So there's a ABCDE criteria for melanomas. You remember as asymmetry, border, color, variation, any new changes. So all of them are covered. If you think about and match with our question, all of them have been covered actually. And as you all can see, the first step in the biopsy, first step should be the biopsy to rule out actually, to confirm. Okay. So it's a classic for the melanoma. Uh, do you mind if I show you another slide, guys? I hope I'm not taking too much of your time. A little extra slide. I hope you guys can adjust. It's for your betterment, guys. Now, for the classic melanoma in the exam, so many type of additional question also can come. It's a 5-star rated topic, melanoma. About the melanoma, like most common melanoma, it's a superficial spreading type of melanoma. About melanoma, initially is always excisional biopsy. Is this one matching our question, guys? So one of the initial what we do as an approach, we do an excisional biopsy for melanoma. This is matching. Some cases they just give a very minimal size as a suspicion. Again, we do excisional biopsy wherever you can. You do 2 mm excisional biopsy, but it depends on the size. Bigger size, you have to do much bigger incision to remove it. Melanoma screening also, please double check from the RACGP or from the Red Book. I think you can just type melanoma and can type RACGP, you will find everything. Next important thing is the risk factor. What are the actual risk factors? First, number one risk factor, honestly speaking, if someone has a previous history of melanoma, that is actually a very big risk actually. And on the top of this, there is dysplastic nevus is a big risk factor, and first degree family, and this and that. Okay. About the prognosis, you need to check the thickness. And another thing, melanoma in eye is often given in kids cases. I repeat, melanoma in an eye as a black spot. Uh, Please understand melanoma is very deadly. Australia is a very like sunny country. People love to go to the sunny areas and love to sit in the sun. Also, a lot of people are working in Australia in the field. So it's very, very important. So here we go. Like melanoma in eye is a inoculation actually. Okay. Also, as an occupation, farmer, Darwin, uh, these are the similar thing. Melanoma risk, yes, already mentioned. And also malignant cell at the resected site that also can become as an option actually. Yeah. Okay. Thickness and the depth, I think as per the book, first, I think we'll consider the thickness. The thickness and the depth actually, almost the similar thing actually. It's just the word variation in some cases actually, nothing else. Okay. Either of the option will be given in the question. Like either they will give you thickness, either they will give you the depth actually. Clear, my dear? I have seen the both option coming actually at time to time. Sometimes they give thickness, sometimes they give depth. Okay, this time it's your turn. I'm not reading this question. Please read this question, and you have a very little, like 30 seconds of time to answer this question. The time starts now. So, everyone, time up. So, 68 here, like the question that is how it's mentioned. It is a adenocarcinoma. You see, this is a colon cancer, and this is a adenocarcinoma. Okay. Adenocarcinoma. Now, with the adenocarcinoma, what is that particular stage? Stage 3 adenocarcinoma. With a stage 3, of course, I don't think so we can go for a surgeries and this and that. Um, and diagnosed colon cancer, and this is the exact line we are looking for. So, stage 3 colon cancer, adenocarcinoma can be deadly. So, adjuvant chemotherapy is like a more recommended here. So, some explanation given. Please have a look. I'm giving you a few more seconds to read some of the explanations. Okay. If you want to know more about then what does it N1 means? N1 means there is a lymph node involvement. It means it's locally it started to spread. So quick thing if like N1 is involved and locally started to spread, can we do a surgery in this case? I'm just talking about a basic. Can we do surgery in this case? Some people might think about doctor, why not C? So it's already started to invade. So perhaps maybe it's yet local, but surgery will not be good idea. Why? There's a more possibility of more tumor spreading. So that is why chemotherapy to reduce the recurrent risk of stage 3 disease at this point. And here is a standard regimen. You don't need to memorize the regimen. That is okay. I hope that is clear. And another interesting and very popular topic. So colon cancer, prostate cancer, these are so important for the exam. And I can see these are so important ones. 58-year and presents with a routine follow-up and history of normal PSA. And PSA level is this. And at this visit, PSA level is 2. Okay. With a full moon, and on digital rectal examination, prostate is non-tender, smooth, and without any palatable masses. Patient has no um, symptom of lower urinary tract dysfunction. So, what is the next step in the management? Come, guys, it's a very important question. Check the DRE finding, digital rectal examination finding. He is 58 years. Good news, PSA is within limit. We can see that. As per the age, the PSA looks all right. Age seems also okay. I mean, what do we consider? Age. Age means if life expectancy more than 10 years they have or not. In this case, even more than 20 years life expectancy. We also check PSN. We also check DRE, this thing. We also check any symptom of metastasis. Please check in this question one more time. Is there any symptom of metastasis? Okay. And we also check symptom of metastasis. We also check symptoms of LUTS, lower urinary tract symptoms, actually, because prostate cancer can cause it. Also, benign prostatic hyperplasia, which is very much related to LUT syndrome. They also said no symptoms related to lower urinary tract. Okay. So, in this case, like what to do? So, final answer in this case, what we are thinking. I think the best answer would be in this particular case. Some people say no, B, no, not really B. Yeah, trust, I think there is no indication because patient has no symptom of urinary tract dysfunction. So it is not benign prostatic hyperplasia, I'm afraid. Okay. So this one is out. Prostate biopsy, you need to have PSA or the DRE, either of them positive. Okay. This is out. This is out. So DRE negative, PSA negative. Start treatment for BEP. Why? Because it's not a benign enlargement of the prostate. Now, two options remaining. One is a repeat PSA in 3 months, and one is a discuss potential prostate cancer scan of the patient and repeat in uh, 6 months, actually. Now, this time the things are doubtful. Now, I'm happy discuss about the prostate cancer screening about the patient. Uh, and repeat the PSA in 3 months. One is a repeating PSA in 3 months. Now, this is doubtful. Normally, the best answers in this case talk about the pros and cons about the uh, PSA. In most cases, that is how it looks like. Very interesting question, actually. I would like to happily explain this one. Yes, it is too early. A very good one. The hint is there, actually. Okay, so our PSA level is 2. First of all, is PSA within normal range or not? PSA within normal range. Next question is PSA is diagnostic for cancer? Not really. PSA knows symptoms, no immediate concern. Monitoring, okay. Repeat PSA in 3 months to assess the velocity and this and that. Okay. Now, actually, why I want to do the PSA a little bit more early than usual? Some cases isolated PSA can be raised, like say prostatitis, early initiation of the BEP cases. This PSA can be a little raised actually. So technically, 3 months is early, and also technically 6 months is less for me. So I would like to double check in that PSA in little shorter time. Is it clear, everyone? Because my PSA here, do you think is little raised than the usual? What do you think? You see, prior screening with a PSA 0.9 recorded 2 years ago, and this visit PSA is 2. So, did you see any difference on that one? So, perhaps why, like, zero point 0.9 would have been, of course, fine, but now came for the routine one, and that PSA is 2. But is it an isolated PSA raised or not? That is my concern. So, there is a term you can use as a isolated PSA, maybe an early initiation of benign prostatic hyperplasia, or probably maybe a prostatitis. So in 3 monthly, yes. You can check the Cancer Council in Australia for this particular section. RCGP and the Cancer Council in Australia. This one is little tricky. I mean, the best possibly what we found in the question often, um, talk to the patient about the pros and cons about the prostate cancer and PSA. That is the perfect answer here. We are, I think, yet going for, you know, it's very close call actually. Before moving, let us double check one more time. I'll go for the A. Yeah. Okay. A little early detection would be more. Um, yeah, as like the lot of new changes in AMC, they will set more questions like this in coming days. Like, the same thing, like see, A and E are more same thing. So your clinical reasoning, remember the day one on the lecture, I talked about the term clinical reasoning. So you know about the disease, and many other know about the disease, but your clinical judgment and the expertise will play a part. So, example, here we are choosing the PSA for 3 months from the clinical judgment and the expertise. So that will be tested more in the exam actually. Okay, because I'm explaining this one, that's why it's coming like that. Uh, yeah. That'll be better actually. Okay. No worries. I have posted that question in our guideline group. You guys can participate there. Okay. Into that one. Maybe I can come up with another explanation that time actually. Okay. I posted that one. Take participation on that one. Comment as like you are going for A and EY. We can have a nice discussion there actually, so that it does not vanish. After class, please check it. I have posted there. Okay. 60-year old man brought to the emergency department with a progressive weight loss, new onset of confusion over last 24 hours. So if 80-year person, the new onset confusion, the family reports he fell at home few days ago and he had not sought medical attention. CT scan revealed a subdural hematoma, Glasgow coma scale, and hypotensive blood pressure. This no clear history of anticoagulant use, and he is on aspirin for cardiovascular disease. What is the appropriate next step in the management? Yes, please. So the person is wired, the person is in emergency department, the person has confusion, the person's GCS is low, and the person's blood pressure is quite a low. Plus 5 seconds. 5, 4, 3, 2, 1. Okay. B, D, lot of answers are coming. It's mentioned like a bit subdural hematoma. Somehow it has happened. Subdural hematoma. Now, if it's a uh, subdural hematoma, now what to do in that case? Should we perform an urgent craniotomy in this case, or should we review in this case? So there is a history. So there was I think, long lucid interval that leads to subdural hematoma. So long lucid interval and leading to subdural hematoma. I think any of these cases are urgent, what we understood. Let me show you something from our stock. First of all, this will clarify most of the thing. I hope so you will enjoy this part. Okay. So here is that slide, and 88-year person, it's a very similar kind with a previous history, sleep on a bathtub 4 weeks ago. Now he was brought and confused. Now she's having localized pain is localized in his head and open sign of painful stimuli. Okay, so there was like a 1 month gap, and it was subdural hematoma. What vessel affected and this and that. Bridging veins are affected. Best step in this case is to rule out by a head CT. Now, in this question, let's come back and see. a CT which is already done and it is showing subdural hematoma very loud and clear. If it's a hematoma loud and clear, immediate surgical evaluation and hematoma evacuation, either bar hole or a craniotomy. Okay, these are book references given here. So I think for this question, what do you think? Again, what is the right answer? I think the better would be if any subdural hematoma, if it's a subdural hematoma, first you need to look, because the more you wait, now what is the problem of waiting? The option D or any other option, the problem of waiting. Yes, CT has been done. So the problem of waiting could be damaging more part of the brain over the time. More focal deficit would be there over the time. Okay, so I take up this print. So give me a second to correct it. So I'd go with the right answer as an A. I'm taking a second just to add that particular reference here. Yes. So in our case also, there was a bit long lucid interval. And many cases, I think in this type of question, CT scan would be also given, because when it also comment based on the CT scan, uh, if you check into lot of articles like in subdural hematoma cases, can we some cases wait? And again, it depends on some cases CT scans actually, honestly, because CT scan is missing here. So we actually cannot directly comment, but if it's the classic subdural hematoma, definitely the surgical evacuation is a must actually. All right. So we'd like to go for this answer as an urgent anatomy to evacuate the hematoma, assuming, I think, by the CT scan, assuming as a CT scan would show a proper hematoma. Are we clear? I mean, I'm expecting the hematoma they're talking about is uh, certainly hematoma they're talking about certainly would be uh, a clear view of like the hematomas actually. There would be a clear view of hematoma. So it depends on the CT scan, like a midline shifting, brain herniation, this particular things would be there. This is how the most CT scans are given actually. Great. So I think at this particular level, the questions are not too deep to confuse the IMGs actually, especially in extreme neurosurgical questions, they usually don't test it. So I think it would be urgent craniotomy or hematoma would be the answer. Yeah, I added that one in the slide. I will add that slide soon after the class. We're doing the May 2025 recalls actually. Following, we'll do the June in coming week. So subdural hematoma is the classic finding as per it is given. So here is a line. Let's read this line again. Immediate surgical evacuation and hematoma evacuation through either a bowel conduit. Surgical evacuation is indicated by on any subdural hematoma with any minimal amount of bleeding or anatomical damage. So we believe that the subdural hematoma in the picture we are getting, there would be any bleeding definitely, or as the hematomas, midline shifting, GCS, and this and that actually. All right. Again, depends on the CT scans, the questions. 80-year woman with a previously worked in a construction presents with a 3 month history of tinnitus, reducing hearing, and Renée-Siebert's number, and that ear examination is unremarkable. She's currently taking a particular new drug for hypertension, which is the most appropriate next step in the management. Interesting question. Appropriate next step. So in 3 months, there is tinnitus and reduced hearing. So very interesting, this question. Is it going for an MRI or is it going for a ENT specialist? The facts are given though in that question. If you see that Renée-Siebert's are normal and examination unable, she is taking some sort of antihypertensive drug, mentioning that reduced hearing and the tinnitus, what they are hearing actually. So is it a question related to refer to an ENT specialist or doing an MRI first? Okay. Tinnitus and the hearing loss with a ATR. Tinnitus and hearing loss in a, yeah. Okay. One more thing. If Rene's and Weber's test are normal, um, first I'd like to ask you guys, is your interpretation about Rene's and Weber is absolutely spot on? I would like to ask this thing. Is your Rene's and the Weber is absolutely spot on because it said Rene's and Weber's are normal and sensory neural hearing loss. Did you understand this line well? If you really know it very well, then only it is possible that you understood this line. Keep going, guys. So why everyone's, I think, supposed to be very advanced. Okay. Then do you want me to explain the Renes and the Weber? Yeah, I think that would be more wise at this point. Let me explain then. Give me some time. I Let me bring out the John Murtak, that particular line. Taking 1 minute because I'm opening John Murtak. Some of you are supposed to be from the 5 months course. I believe you are supposed to know. In next 30 seconds, we'll start. Okay. Okay. So that's the question with the 80 year with the tinnitus and the hearing loss. It is big. I mean, if anyone feels like, they are um, too weak, yeah, they're too like, weak regarding the theoretical part and accidentally into recall course first uh, to go through this particular thing. So I brought that reference from the John Murdoch, added into this slide. It was not before. That's why I took that screen away. Okay. Now, coming to this part, like from John Murdoch, first I took this particular section, which included conductive deafness and the sensory neural deafness. In our question, it was mentioned that Rennie's and Weber's are normal. Okay. But we are still thinking this can be a sensory neural deafness. Now, these are some of the example of sensory neurons can be presbycusis, is very noise-induced deafness. Is our person is a construction worker? Is it possible this person over the time, because of lot construction work, there is a sensory neural deafness? Now, example, not only construction worker, nowadays, a lot of people are, they are DJ. Is it also possible that DJ, they are over the time also having sensory neural deafness? The same thing. In future question can be like that. Yes. So over the time, they are also developing these issues. Interestingly, here in this question mentioned, sensory neural um, Reni's Weber's are normal. Still, they are considering this thing as a sensory neural hearing loss. Okay. Now, first of all, these are some of the sensory neural. For our one, this can be noise induced high likely, but consider Meniere's, consider some other things if those are the differentials, whereas some of them are conductive, example, autosclerosis, cholesteatoma, otitis externa, these are conductive deafness. Anything that causes deafness is a deafness, cannot hear properly, can be associated with so many other conditions like tinnitus, this and that. Coming to the Reni's and the Weber's comparison, here we go. Like first you need to see what's in the normal. Did you know this particular thing? Like when usually we do the Rinnis test, the normal cases, the Rinnis test, when we do a Rinnis test, in that case, we there's a certain type of tuning fork. So we hit the tuning fork and we put it behind the ear to see like first here and then behind the ear, right? So the use of the Rinnis test is done, right? So you hit the tuning fork, like can you hear? And then at some point, still can you hear? Normally, what is the interpretation in a normal person? Like, so we check in the ear, then in the bone, then again in the ear. So it means they said, they can hear better or more in the ear than the bones actually. So the bony hearing goes away. Now, through the bones, can you hear? Like now, just a lot of headphones are also made. You see, there's a headphone. They touch the bone, and you can hear the sound. So the bony hearing it is possible actually. So is it normal for people like you do like this, but you do in the behind, you cannot hear in the bone actually because air conduction is better than the bony conduction. Everyone, please mention the first one as agreed if you have agreed. I mean, as a generally. I mean, it's like if this is a tuning fork and you put in the ear, you can hear at time point, like, you put in the board, you can't hear, but again, you put in the in front of ear, they said, yeah, they can hear. So ear is better than the bony, and now as an interpretation, this is normal actually. This is a normal interpretation for normal people. This is the same interpretation for sensory neural deafness as well. Please note it down. This is the same interpretation for the sensory neural deafness. Now, the question remains here in this case that uh, then how we differentiate conductive deafness and the sensory neural deafness. Okay, now how we differentiate normal and the sensory neural, because conductive deafness has a different setting. In the beginning, if they say they hear better in the bony, it's going towards the conductive. So with the very first test, you can differentiate. But normal and the sensory neural has similar finding. Then what way we can differentiate normal versus sensory neural? Answer, we do the Weber's test, right? That is the reason we do the Weber's test actually. So Weber's test will help differentiating these things. Weber's test help differentiating these things actually. Okay. All right. So normally, yes, louder in the better ear. In Weber's, louder in the better ear. In Condrati's, louder in the deaf ear, which is, so in our question, like totally it's not given, uh, perhaps properly. They said like uh, Weber's units are normal, actually, not fully uh, given things here, actually. Like Rennie's Weber's normal, but still it can be sensory neural by the based on that, Weber's actually, as we mentioned, actually, like this question may not be fully given, but based on the consumption and long time weight loss, it's a possibility of sensory neural deafness, actually, sensory neural deafness. Okay, now, is it we are supposed to refer it you know, uh, to ENT, or should we go for an ENT? That is a doubtful thing. Anytime in AMC, if situations comes like this type of situations, so history of noise exposure advances is a common presentation in research. Okay, can be sensory neural hearing loss. Okay, next step we have chosen, like next step, MRI of the brain constituting cerebellopontine angle tumor. That is a like a possibility in this case. That is a possibility. But I think situations like this, I think even doing that MRI and this and that, I think even situation like this, usually the ENT will decide actually, to be honest. Okay. So I think I would pick up this one. Would be the better answer. What do you think? I know everyone agreed with that one. Let the ENT decide whether they like to go for a uh, neurological examination more and would like to go for a audiometry more. I think the uh, neurological doctor will decide that would be better in these cases. Okay. MRI is a quite a big test in those countries actually. Mostly it is done by the specialist actually. So this interpretation is important, like normal and conductive and sensory neural. And normal and sensory almost are the same. Then we differentiate it by a conductive deafness test. Okay, great. Okay, guys. So we'll go for a break, and when we will come back, and then we'll do the remaining. Okay, guys. I think you need a little break here. It's okay. Slow, steady wins the race. Uh, we'll do the remaining after a 10-minute break, actually. Thank you so much, guys. We have another 1 hour class left. Thank you. হ্যাঁ, এটা আশিক, এটা ঠিক আছে, কিন্তু সকালে যে বন্ধ এটা তো লেখো নাই আর কি। আমাদের জিম আহ মানে 3টা থেকে 11টা পর্যন্ত খোলা থাকবে। আহ এখানে লিখে দাও যে জিম ওপেন হবে হচ্ছে 3টার সময়। হ্যাঁ, এবং যে আমাদের জিম আহ ওই যে উক্ত তারিখে 4 তারিখে ওপেন হবে আহ 3টার সময়, এবং রাত 11:30 পর্যন্ত খোলা থাকবে। সকালে জিমটা বন্ধ থাকবে, এটা আর কি লিখে দাও। ব্যবস্থা সামলাও, হ্যাঁ, ঠিক আছে। বৃহস্পতিবারটা আমার ফেসবুকে আপনি ধরে বৃহস্পতিবার ফেসবুকে একবারে আমার ম্যাটেরিয়াল গুলো একটু জমা গেছে। Understand? All right, everyone, let's get started. All right, everyone. So I added something here, which you will find in the slide, which you can see like proper preparation, like a kind of like a life cycle, like how start proper preparation, then last few months, last day of the exam. So few tips been given here. You can check them at your convenience. Let's start with that another file. 65-year-old, like COPD complaining of saturation with the Hudson. ABG has some finding and Hudson not discontinued eventually it's been given. So what is the appropriate next step in oxygen therapy? By the way, guys, oxygen therapy related question I have seen in MC in past coming on and off. So what do you think? This one is a little difficult, but if you think logically, yeah. Okay. A lot of people went for this one, non-invasive ventilation. A quick thing, non-invasive ventilation, if I show you a chart particularly, when is non-invasive ventilation? A very interesting first question. 85% and less, then you can consider non-invasive. Now, let's come and see this question first of all. With a 82% with the Hudson, ABG is kind of Hudson discontinued, eventually, is initiated. So the question was, how would you continue actually in COPD? Control oxygen saves life, of course. You must be knowing, like in case of COPD, you need to give oxygen in a proper manner, right? So patient reached targets so too, like this thing, ensure provides precise control of delivery. Critical for the patients with a chronic hypertonic respiratory failure who have planned, hypoxic drive actually. You must be knowing that, a basic thing in asthma, high flow, and in COPD, a low flow oxygen, that is more important. Some of you, like, uh, some of you answering this question as a non-invasive ventilation. Non-invasive ventilation is like not this one. This is certainly not non-invasive. Instead, we are going for is this one as a venturi mask actually. Okay. For knowing more, I think this one was a little bit more difficult one, a bit more difficult one. So we would like to uh, focus more on the venturi at this point because it is 8 less than the, it's not beyond less than the 85. So if 85 or less, let's say 83, 84, something like that, non-specific ventilation. Otherwise, continuing at our particular state venturi is fine. Is it clear, everyone? A little difficult, but you need to understand that oxygen drive, carbon dioxide things in case of like COPD and asthma, which is little different actually. A little bit difficult question, but I think it is okay actually. We can go with the eventually as per the percentage of the oxygen. If you want to keep it easy, this slide is easy for you. If you want to go with a more detailing, for study, this one is more recommended regarding the oxygen therapy. Please confirm as a yes, like so that you can continue with the next slide. We don't want to keep it too long actually. Medical thing is so big, there's so many lectures and this and that, even with the oxygen therapy, there can be 3 hours, 4 hours lecture, right? Okay, 70-year-old patient previously well with the COPD, salbutamol, monotherapy, now presents with the worsening of dyspnea. Now, always check one thing, a tip for you guys, like whenever you see a chronic condition, always check your case is all right or your case is worsening. In our case, this is worsening of dyspnea, and so it's not a um, fully controlled with probably with the therapy, monotherapy, salbutamol. Saba is being given actually. Now, symptoms are persistent. Now, this is another red flag, and functional capacity declared additional in this management. I think it's a easy peasy one actually. Always think one thing about the asthma, the COPD treatment. When the initial SABA is not working, there is always a combination therapy we come up. Among that combination therapy, one thing is definitely should be added is a steroid, the ICS. So any answer with the ICS can be right. Okay, so this is very, very important. So the best answer in this particular case is a ICS, and a combination is a better choice. Is it clear to everyone? Like, why you can see many of the like asthma, the COPD, the managements, when you need a step up is always a combination actually. Some of you are new here, some of you came through our academic courses before. You saw some of the few things with asthma, there was always a combination of the treatment. We're not going into much detail, but I think I already explained. So it's called escalation to maintenance therapy. Then SAMA is failed, then we're going for a combination, and which also includes the ICS definitely. Great. Next one. You can check the slide. I will upload the slide so you can check into the later into the May folder, May 2025. What we are doing today, May 2025. I'll upload these slides again actually. Some of the new slides we made for you. 25-year-old presents with a millimeter painful abscess localized on lower eyelid margin. Clinical examination it is tender, erythematous nodule consistent with hordeolum and sorry, like no periorbital cellulitis. This is important question. Higher chances in the main exam, they'll give you a picture of IX as well. No peritoneal cellulitis or systematic symptom. What is the right management? First, your diagnosis, please. Now, this is a situation with a painful abscess in the lower eyelid margin. Yeah. So answer is here. This is a higher chances that as a first line of the management, this is I mean, I think any cases like if you remember your eye classes, dye and the calazion, both of these cases almost always can be because of hygiene, and often it is recommended like warm compression. Did you remember this, guys? Like, from your eye placement, like any sty calazion cases, it is always a warm compression, initially. And if it is not working, alongside, we also started some flucloxacillin antibiotic, right? And if calazion is too big, some cases, we need to remove surgically by calazion clamp. Yeah. So again, few things. It's also available in John Mutta, this particular two things, sty and the calazion actually. Sty and the calazion actually. Calazion is more like at this point, whereas sty is kind of like here actually, often known as the internal hordeolum. Often it is caused by, staph aureus actually. Great. Stay collagen is an easy topic. I think let's not waste much time here. Uh, a quick question to help you guys. Is it often self-limiting or do you need anything? Most cases. Any sty and the collagen, what do you think? Most cases are they self-limiting or you need to give something? Most cases they're self-limiting. Most cases it's just a conservative advice, like use warm compression. Take a towel, put some steam on it, and you just keep compressing that. Within 3, 4, or 7 days, it will be totally fine. So most cases they're self-limiting. This sty and the collagen related things actually. Wonderful. Sty, sty and the collagen. Moving forward. All right. A 55-year male with a type 2 diabetes now in the emergency department. Type 2 emergency. I hope you start processing what it can happen. Crushing the chest pain to the left arm accompanied by diaphoresis nausea. Okay. And pain onset was 45 minutes ago and ECG finding was also given. Interesting. It's a very classic question about chest pain, right guys? It's a very classic question regarding the, central chest pain and which is radiating and also ECG is showing. So certainly it is a myocardial infarction and if it's a urgent PCI, which is a gold standard. Urgent PCI is a gold standard. Now, in speaking about MI, which type of MI it is? It is an anterior MI actually because V1 to V6. If it would have been mentioned V5 and V6, then it would have been lateral MI. If V1 to V1, V2 and L5, L6 given, together, then it's a antero lateral MI. I hope that's clear actually to all the doctors. Okay, so gold standard is always this PCI thing. Gold standard is always this PCI thing. Okay, as per the John Murtagh, it is mentioned like a 90-minute. As per the John Murtagh, it was mentioned 90-minute, but actually by 6 hours you can do the PCI. Am I right, guys? By 6 hours, actually you can do it actually. Okay. Now, initial, it's not like a MONA. If the patient already presented, see, if the patient is always presented, in the emergency department, now why would you give MONA actually, if in that particular area, if you have that PCI and this that available, and you are asking to choose most appropriate among them actually. This MI question comes in various way. One, the patient comes like nearest hospital where you don't have all the facilities. In that particular cases is often that is the moment actually. Clear? Great. Wonderful. A 40-year-old female presents with a 2 weeks history of progressive fatigue, unintentional weight loss. By the way, guys, SMA note section has a AMI related note. Please double check it. Unintentional weight loss, polyuria, polydipsia, no significant past medical history, random blood glucose measures, this level. Important information, blood glucose this level. Urinalysis showing no ketone actually. So what do you think? 10 seconds more. The person is 40 years. There's a 2 weeks history of, yes, weight loss, polyuria, polydipsia. So it's a classic case of diabetes actually. It's a classic case of diabetes actually. Do you want me to explain this thing more? I think weight loss, polyuria, polydipsia, they start feeling fatigue, blood glucose level high. I think nothing really to explain too much. Okay. And other than diabetes, you can also get diabetic complication related questions too, actually, like diabetic nephropathy, diabetic neuropathy, if diabetes is not controlled, diabetic foot as well. For diabetic foot cases, meticulous foot care. Another popular thing it can be meticulous foot care. Another popular in the exam would be diabetic ketoacidosis as well. Next, 25-year-old male, prior medical history, Now presents to the emergency department. First witnessed following his first witness of generalized tuberculosis, the episode was like 90-second, elevation normal alert, and what is the initial management? Interesting question. Generalized tonic and clonic seizure, which is like a 90-second. Okay, quick thing. Neurological examination is normal. Do we need to go for a MRI in this case? Interesting. Also, another point is very important. Is this a first time seizure or a recurrent seizure? Also, if there is any head trauma or anything else, any head trauma, no head trauma, any sign of meningitis or something, not really. Any sign mentioning, subarachnoid hemorrhage type of features like worse headache ever, something like that, or focal neurological deficit. Very important. Any focal neurological deficit. Any sign do you think intracranial hemorrhage? Neurological examination is again normal. Patient is alert and patient is oriented. If it's intracranial hemorrhage, patient might be confused. Without focal deficit, I don't think so. It's a good idea for first time. So I think you understand now what is the answer. It's an observation. Everyone agreed? I think it's a first time seizure. It can be because of electrolyte. Did you remember there was a if anyone from the 5 months I mentioned something. If it's a first time seizure, what you should check first actually? You should check electrolyte first. See, you may anyone can have also seizures. Like it doesn't mean we have epilepsy. So it's electrolyte. If it's a recurrent seizure, then it's a glucose level. Then it's a glucose level. Okay. Next is a 60-year female with a poorly controlled hypertension presents with sudden onset of severe headache or headache and vomiting, and blood pressure on arrival is this. And non-contrast CT reveals 3 centimeter uh, subcortical hemorrhage in the right basal ganglia. What is the next step in the management? So here you can see in this CT there is a little bit like this hemorrhage thing. 3 centimeter hemorrhage. Yeah. Also mention orthostatic, this and that. All orthostatic doesn't mean it can be subarachnoid hemorrhage, but basically the term is hemorrhage. So intracranial hemorrhage is a possibility. Now, what to do in this case? We're going for our answer now. Answer is at this particular point, is it very important to control this so high blood pressure? The answer is a yes. Very important to control the blood pressure. It's intracranial hemorrhage as per the Australian stroke guideline, lowering the systolic blood pressure below 180. So our first target is to control over this situation, which the systolic is too high, bring it down below 120, whereas the target is 140 260, you know, in the first hour to prevent hematoma expansion. Whereas this labetalol thing is the better choice in this case. Everyone clear? So any stroke, definitely hypertension is a risk factor for a stroke. When stroke is happening, you need to slow down the blood pressure as well to prevent further expansion. Now, there is another thing, uh, term. Is there any regulation of, uh, you know, putting down the blood pressure too fast? Something? Is there any protocol of lowering the blood pressure in stroke, especially hemorrhagic stroke or in ischemic stroke? Especially in the ischemic stroke, if you like suddenly reduce the blood pressure too fast, like that can be a reverse effect actually. That can be a reverse effect in this. This one is a hemorrhagic one actually. Okay. Yeah. This one is a guideline for the hemorrhagic one actually. As you can see, main target guideline showing the blood pressure less than 180 as soon as possible. If we talk about the ischemic stroke, it's the margin of 15% reduction, per hour, 15% reduction in ischemic stroke. All right. So lower the blood pressure first. Without not lowering, you cannot go for even surgery. Nifedipine is not labetalol is the choice actually. And also some cases are even nifedipine even contraindicated in some of the intracranial hemorrhages actually. Okay. This question is not related to head injuries and things like that, so we don't need this osmotic one here. All right. Next, a 30-year-old male presents to the 3-day history of fever, sore throat, this. I think a very similar one we have seen in the other file today. Yeah, because it's a May one, so when we're doing a lot of files, 1, 2 can be similar. So here we go. This one's answer, not going for much explanation, is a infectious mononucleosis with a classic tired fever, pharyngitis, lymphadenopathy with atypical lymphocytes on the blood film. About the others, we have explained earlier in time to time. Uh, One particular chart can be helpful for all. Let me show that one. It's actually this was there in previous John Muttak edition, but this one somehow they removed in the current, you know. So in a previous John Muttak, it was there actually. So Epstein-Barr virus versus HIV versus cytomegalovirus versus toxoplasmosis. Okay, maybe you can take a picture of this one. You see, few of the things are quite a common in them, like fever, sore throat, tonsillar involvement, organomegaly, whereas the HIV line is kind of different compared to the others. But some of the initial presentation is similar in HIV, which includes the fatigue, weakness, yeah, this particular thing, and tonsillar involvement. So hence, HIV is put into this category. All right. Among them, Epstein-Barr virus and toxoplasmosis are more important, whereas toxoplasmosis has some connection with the cats as well. So keep it in mind, actually. All of them has some sort of cervical lymphadenopathy. Great. Next question. A 50-year male with a lot cigarette. Anyone who is, smoking like 20 like cigarettes a day, it's very high risk of having cancer in future. Like chain smoker, what do you mean by smoking history? Presents a two-week history of hemoptysis and weight loss. X-ray demonstrates 3 centimeter solitary pulmonary nodule in the upper lobe. So what is the most appropriate next step? So this is a pulmonary, like you see, lung mass. They mention the size, 3 centimeter lung mass. So if there is a 3 centimeter lung mass, what to do? Definitely we are going to order a CT scan to rule out the size, extension, or any other thing. All right. It was an easy one actually, because to rule out the lung mass, definitely order a CT. I didn't go for much explanation. You can see the explanation later. We are also running a little short of time and we all are tired, I'd say. Maybe in another one we can explain more. 45-year, presents with a 2 months history of palpitation, heat only, unintentional weight loss. She reports tremor and anxiety. Thyroid function test revealed this and also this. What is the most appropriate initial treatment? So first of all, diagnose this case. It's a female, 45, middle age. So palpitation, heat only, so it's a very classic case of hyperthyroidism. Now, if it's a case of hyperthyroidism, first we have to look into, is this a pregnancy relevant condition or not? It does not really look like a pregnancy relevant condition, but that's okay. So thyrotoxicosis, like how to deal with this thyrotoxicosis. Now you need to also figure out what sort of thyrotoxicosis is this, because there are primary, there are also some cases secondary. So you see TSH is low and T4 is high. So it looks like it's a primary, right? It's a very classic one actually. TSH low, T3, T4 high. So it's a thyrotoxicosis. Since it's a thyrotoxicosis, so what do you think with the answer? Now, is it a drug? Is it a radioactive iodine therapy or is it an observation? What do you think? Yeah, keep going, guys. It's okay. Let me show you certain things. So this part is related to thyrotoxicosis. Often cause can be Graves and many other things. It can be interrelated with atrial fibrillation in some cases. Okay, so definitely TSH low, T3, T4 high. That's the classic one. Speaking about the treatment, generally treatment radioactive iodine therapy and anti-thyroid drug, carbimazole, propylthiouracil, and the adjunctive drug can be uh, beta blockers. If say acute florid phase, if it is there. If it's solely because of the Graves' disease, you know, younger with small goiter, and this case is again anti-thyroid drugs. If it's a bit older cases, above radio iodine, uh, large goiter or moderate severe cases, anti-thyroid drug till euthyroid. One line they have mentioned in Australia, radioactive iodine is currently increasing a lot. So younger patient and mild cases, I think they prefer more about the anti-thyroid medications more. So coming back to this one, uh, nothing mentioned about classic goiter, first of all. Let's have a look on this question, everyone. Our answer in between propylthiouracil, radioactive iodine, and propanolol. Um, One important thing is our patient is stabilized yet. I mean, this thyrotoxicosis is our patient is stabilized or not, because this radioactive iodine therapy it should introduce you know after diagnosis and stabilization, right? This is like a just presented symptomatic hyperthyroidism. Now, a very close one was propylthiouracil. Maybe most people have doubt on that one. Propylthiouracil is a more choice when it's a pregnancy and thyroid strong. These cases, we consider this thing a bit more. Our patient also has palpitation, please note. Since our patient also has palpitation, so very obvious reason, the best possible one would be to immediate symptom releasing, like beta blocker would be the priority, because it is a symptomatic hyperthyroidism. I repeat, guys, this is a case of symptomatic. Propranolol will counteract the symptoms of palpitation, tremor, and the anxiety. Clear, everyone? This thing. Beta blocker is the drug actually, it has very good effect on anxiety, tremor, and the palpitation compared to the other anti-thyroid drugs. So for immediate symptom control, it's a beta blocker. As a definitive, you can go for later anti-thyroid drugs further. Okay. All right. Now you need to make further diagnoses, ruling out Graves, maybe when you have eye symptoms. So the radioactive iodine thing is mainly the treatment for the Graves cases, but our case is not a confirmed case of Grave. Why not? There is no eye symptom, but eye symptom is not everything, but there has to be uh, stimulating autoantibodies has to be positive. Grave has also autoantibodies positive, so those are not mentioned here. Is it clear? This chart is a nice one, guys. Agreed, guys? This chart is a nice one, actually. Okay, I hope it's clear. It's one is a symptomatic, like patient presented with a lot of symptoms like palpitation, like anxiety, stress. Like in that case, beta blocker is better because it has a good effect. And for the definitive cases, established cases, then we go for that typical antithyroid drugs. Also, like maybe radioactive ablation can be considered. And further established case of Graves, which is usually a number one case of hyperthyroid. But Graves is not always the only thing, but it's if it's established Graves case, radioactive iodine therapy can be a choice actually. Is it clear so far, guys? Another angle of management we just learned about the hyperthyroidism. Yes, great. Okay. Okay. Next is a 28-year female presents with a 6 months history of irregular menstrual cycle, increases facial hair and acne. She gained 8 kg over past few years. We understand this is a like PCOS because there is multiple cyst in the ovaries, so likely diagnosis actually. Yeah. Bilateral cystic ovary. I think it's an easy one, like uh, PCOS. I mean, so another criteria is a Rotterdam criteria: irregular cycle, androgen excess, and lot of cyst in the ovaries. Actually, this is a triad for PCOS. This is a triad for PCOS, also known as the Rotterdam criteria. This chart can be helpful to rule out many other PCOS condition. Often in many PCOS condition, because we found infertile couple. So in that case, we start usually with the FSH and the MH. This is also one of the very popular in the exam. This is one of the things which is very popular in the exam, like a how to start the PCOS diagnosis. This is often the FSH and the LH. Okay, we're not going for a huge discussion on that one. Um, let's go for the next one. We have like three or four more. Okay, 75-year male and with a acute retention of urine and severe, suprapubic discomfort. He hasn't passed urine for 12 hours. Okay, so the bladder scan showing 800 ml of retained urine and urethral catheter is successfully inserted. Draining is a of 750 ml of clear urine immediately. What is the next step? First of all, it's a case related to urinary retention. And because of the retention, there is a suprapubic discomfort. Hasn't passed, so it's a oliguria case, definitely. And you did bladder scan and showing retained urine, so what to do? Is it important to do a DRE examination, guys? Digital rectal examination. I'm sure you know what is digital rectal examination is. Yeah. Now let's explain why it is first. All right. Digital rectal examination. In retention of the urine cases, like often caused by BEP, retention of the urine often caused by the benign prostatic hyperpressure. So very, very important. You check the digital rectal examination to rule out the benign prostatic hyperplasia. Very important. So coming to this one, they offered you tests, they offered you, um, examination procedure. These are getting more popular in the exam. They offer a test, they offer a procedure. So I think here doing that procedure before going for the test is important. Now, another thing, you can check the PSA, you can go for something else. Which one to be done first? Is it a DRE or is it a PSA? Often there should be a gap between that. Now you should do the DRE and there should be a gap to uh, do the PSA. Otherwise, after DRE, the PSA level can be elevated a little bit. Okay. So check the DRE thing first, then you can consider removing the catheter and this and that. So DRE evaluates the prostate size, symmetry, nodularity, suggests the BPH. So rule out that benign prostatic hyperplasia first. Okay. A 19-year man with a sudden onset of scrotal pain and swelling began 6 hours ago. So it's a testicular pain looks like. Reports nausea and vomiting, not uncommon, and they also give scrotum finding. Please check it. Chemistic reflex is affected, by the way, but what is the most appropriate management? I think you all must be knowing this situation is considered as an emergency, which is what testicular situation, testicular torsion. Because severe onset of testicular pain, and it's already been 6 hours actually. So it is highly recommended. I mean, do we have time for even ultrasound and this and that? Not really. So you should quickly go for a surgical exploration of for the testicular torsion. Okay. So absent cremasteric reflex in acute testicular is a very highly suspected for testicular torsion. Cremasteric reflex is like gold standard test, clinical test. Okay, testicular torsion. But I think this chart will help you more. If you check handbook, there is a relevant question 2.017 torsion versus epididymoarthritis. Okay, it's a special test why I want to highlight. If you gentle elevate the testes, the pain aggravates. There was a question like that. Gentle elevation of the testicle, pain aggravates. Yes, France sign. So that's an indicator that this is a torsion. Whereas epididymoarthritis has an opposite effect. If you elevate the testicle, the pain will be relieved. Also, they have dysuria feature, urinary features in case of epididymoarthritis. Okay, that is great. When you're reading testicular torsion, do read about the testicular cancer, 5-star for the exam. So this is how the question was. We were going for C, perform urgent surgical exploration. Heading almost towards the end, a 60-year female with a arthritis this that, with a 2-day history of fever, and joint is this. Well, so what is your appropriate management? Yes, please. Already known case of arthritis and now right knee involvement. I'm sure you are already getting it. Some people will think maybe this is again rheumatoid arthritis flare up. But those are smart. They know this is a septic arthritis because it is unilateral. You see this? They mention this is a unilateral now. Okay. And they said one particular said right knee. So known case of RA. Now unilateral presentation, highly suspected for septic arthritis because they also have the fever thing and also pain thing. So this is you without any further delay, what to do in this case. They didn't offer you anything like arthrocentesis, right? Since arthrocentesis is not offered, so in this case, definitely IV antibiotic. Now, if I offer you another option, arthrocentesis, which one you would pick up? Arthrocentesis or IV antibiotic? In that particular case, arthrocentesis first. Our diagnosis here is a septic arthritis. Wonderful. So is a scenario given again. You can check it from the note later on. So that like similar kind of situation, we do the arthosynthesis later on. You can give like Fluclox as an IV as an antibiotic. Fluclox or Diclox as an antibiotic in septic arthritis. 50 year with alcoholic excess with a severe epigastric pain. So this is a chief complaint. Always consider chief complaint, and it is radiating. Pain began 6 hours ago, now progressively worsen. These are the vitals given. What is the appropriate uh, step of management? Come on, guys, hurry up. Pain began 6 hours ago, guys. And here is another thing, amylase raised. So since amylase raised, you can understand immediately. So this is definitely pancreatitis. So if it is a pancreatitis, it's an emergency. It's an emergency. Okay, so we'll consider this thing as acute pancreatitis. If it's acute pancreatitis, initially it is always, what do you think? Most important initial, like, shouldn't we go for IV fluid first before this one? Of course, we'll go for performing ERCP, but isn't it a situation like this? We should consider, yeah, because they mention most appropriate initial. IV fluid always first, cases like this. Guys, pancreatitis, if you see, open the Davidson, see the very first thing, IV fluid, NPO, this is the first thing they started actually. Any pancreatitis cases, definitely IV fluid mandatory, guys. Yes. So as a management of pancreatitis, even in the first line, immediate resuscitation, number one, number one. Okay. Then, symptom control, then, you can do the other things, to do further diagnosis by CT, this and that. But, immediately you cannot avoid the IV fluid controlling. Okay. Now later comes the ERCP to rule out is it a pancreatic or biliary or any other thing. Clear now, everyone? Why the answer is not C and A? I'm 100% sure. I mean, some question we have doubts sometimes, but this one is 100% sure. All right. So thank you, my dear doctors, today for attending the session. I hope you find it helpful. First of all, the session. Uh, I'll be uploading today's class and also the previous class. I think I didn't upload it yet. So we'll be uploading this one very shortly. And I think the last class also together. So thank you so much for attending the session. My best wishes to all of you. Thank you, guys. Yes. No worries. Thank you so much. Yes, I'll upload actually. Great. Already, if you go to our recall section, yes, the videos already we have been taking classes because we're going through the May now. So the May classes are already, some of the classes are given. So one to new came up, we'll be also add that one. So no worries actually. Great. So good luck. Good night. I hope you enjoyed the session. We are going to close the admission for this batch very soon. So if you have any friends and if you think the sessions are helpful, and definitely uh, gonna help you. Definitely gonna help you actually. All right. And anyone who is joining, has also exam support group for that actually. So if you have some friends, please do recommend. Thank you so much. Anyone is looking for study partner, I mean, please try to find in this group as soon as possible. I'm making a post in our current batch, so you guys can try find a study partner. Okay, thank you.